uh, recently discovered entity of the autoimmune encephalitis, and he was having such kind of the symptoms when the patient present with insomnia or sleep-related issues. There are numerous other autoimmune encephalitis like NMDA receptor encephalitis, which can present with insomnia in the acute phase and hypersomnia in the later phase. Also, the AMPA receptor related encephalitis can present with insomnia or hypersomnia. LGI1 Casper we discussed. DPPX related encephalitis can present with insomnia along with the other domain of the periodic movements and RBDs. Eglon is also known to present with REM sleep behavioral disorders, and MAR2, aquaporin 4, and anti-Hu related encephalitis can present with different spectrum of sleep-related disturbances. So these are few of the fascinating disease entities because these are completely curable with the immunotherapy. And our patient also improves significantly after we have started with IV methylprednisolone followed by IVIG, and now the patient is on azathioprine for the maintenance immunotherapy along with the nerve stabilizers like oxcarbamazepine and pregabalin. So this was one of the example of severe neuropathic pain which was disturbing the sleep, but this was the rare entity. But there are far more common entities which can present with neuropathic pain and the reduced quality of the sleep, reduced amount of the sleep. And the most common is diabetic neuropathy, India being the diabetic capital. So we are seeing many patients of the diabetes, poorly controlled diabetes, who are coming to the neurology OPD with a complaint of burning pain and needle breaking like sensation in the legs, which are disturbing their sleep, as well as the toxic or drug induced neuropathies. Many patients of chronic alcoholism present with small fiber neuropathies, or those of the anti-cancer drugs or second line anti-tubercular drugs taking patient, they present with small fiber neuropathies and pain and picking like sensation in the legs, disturbing their sleep. Sometimes the funicular pain because of the spinal cord pathology can present with primary neuropathic pain, which are more during the sleep and less during the daytime when we are engaged in some kind of activities. So especially perceived during the period of rest, they can mimic the restless leg syndrome, but the nature and distribution of the pain is definitely different from that of the RLS. And some patients of post-stroke pain, and they present with the these kind of the sleep disturbances. And going retrograde, insomnia can aggravate the amount of sleep. Insomnia can cause allodynia, that is due to insomnia, the normal touch-like sensation can be perceived like pain. So there is a bidirectional relationship between neuropathic pain and sleep. Coming to the next case, here is a 30-year-old female who was recently married, but her husband was worried because the wife was having difficulty falling asleep, as well as the wife used to complain pain in legs at night. But not only pain, she was also having some abnormal movements in her legs while asleep. Let us see the video. The video was recorded by her husband, and he sent to us on WhatsApp. So we can see that these kind of movements in the legs were occurring during the sleep time. And the husband was afraid whether she was having some kind of seizure or like that. But she was clearly arousable from such a state, and she was not aware of such kind of movements. And she was also having difficulty falling asleep. So initially the husband was afraid what he was having some superstitious belief, or whether some bad spirit has occupied her soul or like that. So these are clear-cut example of, or the garden variety example of periodic leg movement during the sleep, which was discussed theoretically in detail by the previous speaker, Dr. Nissan. So she was having a periodic leg movement disorder, and the PLMS is closely associated with RLS. In fact, most of the patients of RLS have PLMS, or to be more precise, PLMS is mostly associated with RLS, and 1/3 to 2/3% of RLS reported to have PLMS. The criteria of RLS has already been discussed in the previous talk. And what is the pathology? There is some dysfunction in the dopamine pathway, and not only in the CNS, but as well as in the PNS also, there is some dysregulation in the dopaminergic transmission. That's why and the etiology may be because of some genetic problems or idiopathic problems. But we should always rule out the secondary causes of RLS, be it iron deficiency or in the renal dysfunction, the person having uremic neuropathy or some autoimmune conditions like multiple sclerosis or Guillain-Barré syndrome may have the symptoms suggestive of RLS, and the treatments can be started accordingly by the dopaminergic agonist drugs like ropinirole or pramipexole or pregabalin or gabapentin. Many patients of migraine also have comorbid condition of RLS. In my study, 30 to 40% of migraine patients accepted that they are having difficulty falling asleep because of the pain in the legs, and they were concomitantly given treatment of RLS. One more interesting thing should be kept in mind, because the most commonly used medication for migraine is amitriptyline or beta blocker, but amitriptyline has been reported to worsen the symptom of RLS. So many times when we prescribe the medication for migraine and we forget to ask whether they are having symptoms of RLS or not, so they come in the follow-up with the complaint that Dr. Saab, सर दर्द तो ठीक हो गया लेकिन पैरों में बेचैनी बढ़ गई या कुछ नींद नहीं आ रही है. We generally increase the dose of amitriptyline to increase the sedating effect, but that again worsens the restless leg syndrome and the vicious cycle goes on. So in that condition, we need to be aware of the condition of the RLS, and we need to switch or decrease the dose of amitriptyline and increase the other medication, and we may add pregabalin or gabapentin in such patients to improve the quality of sleep. Now again, this is another case, 60-year-old male. He was not annoyed of his symptoms, but his family members were annoyed because he used to talk during the sleep. And the family members were annoyed that maybe he got infected or infested by some bad spirits. Here is the video which was recorded by their family members. Then he used to talk strange when he used to be in the deep stage of the sleep, as well as he used to move his limbs. And sometimes he used to hit, or sometimes he used to try to have violent movements so strong that may injure the bed partner. So, and this was very disturbing for the family members as well. So this one is an example of REM sleep behavioral disorder. What happens normally during the REM sleep is that the cortex gets stimulated, but the brainstem is switched off so that the hyperactive cortex is not able to stimulate the spinal cord and the muscles and the nerves. But by somehow, if there is loss of this inhibition in the brainstem with the activation of the cortex during the REM sleep, the lower cranial nerves as well as the spinal cord and the limbs are also getting activated, so that the person starts talking during the sleep, whatever he is dreaming, or he may sometimes start acting out his own dreams, which may appear violent, which may injure the bed partner. The RBD is commonly idiopathic. This may be because of some autoimmune conditions like autoimmune encephalitis, which we have discussed in the previous slide, or this may be because of some of the demyelinating conditions like neuromyelitis optica or mood disorders, which are prone to have hypothalamic involvement or brainstem involvement, and they can have these kind of presentation. And also the alpha-synucleinopathy, in which the prototype example is Parkinson's disease or dementia with Lewy body, as well as multiple system atrophy. These three movement disorder Parkinsonian conditions are because of the alpha-synuclein deposition in the brainstem. And in such condition, the REM sleep behavioral disorder may appear years before the onset of classical symptoms of Parkinsonism. So this phenomena of conversion from RBD to the frank Parkinson's is called phenoconversion, and the phenoconversion rate is around 60 to 70% at the interval of 6 to 7 years. Many a times the history of RBD in a patient of Parkinsonism help us, especially when we are dealing with a patient with Parkinsonism. We don't know whether it is because of the degenerative Parkinson disease of the alpha-synucleinopathy, or because of some drug-induced Parkinson's or vascular Parkinsonism, because many times clinically they appear very similar, and the differentiation is really difficult for us. But if the person is having history of RBD, then definitely we are more in favor of the true Parkinson's disease or MSA or DLB. The treatment for RBD is melatonin or low-dose benzodiazepine like clonazepam. Now, here is another case. There was a 36-year-old troubled man. He was going to get married fourth time because the first wife died 3 to 4 months after the marriage. The second wife died again 6 to 8 months after the marriage, and third wife got divorced because she got to know that his previous two wives died during the sleep. Now he was anxious about the fourth marriage. He was not aware. He has not voluntarily killed their wives, but somehow some accident happened during the sleep. This is a true story, and we are having a video of that patient also. We are thankful to the patient that he has agreed to share his video with us. So because some accident used to happen during the deep phase of the sleep when he used to strangulate the wife. So this is the video which was recorded by the patient, that whenever he used to be in the deep state of sleep, he used to have these kind of strange movements. He used to injure the bed partners. And what is different from the phase of the REM sleep behavioral disorders, which we have discussed in the previous section, is that he was not arousable from this kind of the movements or these kind of the episodes, as well as he was not at all aware of these kind of the phenomena of what is happening with him. That's why he was not really guilty of death of his previous two wives. So when we admitted the patient and got the EEG, he was having epileptic discharges arising from the frontal lobe. So he was having diagnosis of nocturnal frontal lobe epilepsy, and this kind of epilepsy used to be a short-lasting event which used to occur mostly during the deep state of sleep. Sometimes we may confuse these kind of the patient from the other sleep parasomnias or non-REM parasomnias, but this is the table which is trying to solve the dilemma, because the frontal lobe epilepsies are mostly short-lasting, stereotyped, and the clustering can be there, and the age of onset is around 14, but the later in the age, while the parasomnias are occurring more in the early age. But whenever we are in doubt, we should go for the video EEG monitoring to record these kind of the events. If the epileptic discharges are present, we may give a trial of anti-epileptic drugs. Even if the EEG is not visible because of the fluid movements, we may get so much amount of the artifacts during recording. We may give a trial of anti-epileptic drugs. Our patient responded well with the carbamazepine, and now he is going to get married happily. Now, sometimes the picture is not clear. These kind of patient may present to us. This video was sent to us by the mother of the child who used to get afraid during the sleep and used to, but he used to be conscious. He used to respond to the commands. So this is a classical example of parasomnias. But in this patient, the patient is not at all aware, and he is having those kind of the eye movement. You can see at the eye, he is having versive movement of the eyes along with the tonic posturing of the lips and the neck movement towards the one side. This is clear-cut example of frontal lobe epilepsy. But the frontal lobe epilepsy may not be clear-cut all the times. In that condition, we need to give anti-epileptic drug trials or the video EEG monitoring. Now, coming to the next case, here is a 55-year-old female who was having progressive walking difficulty. She was literally wheelchair bound. She was having difficulty in swallowing and change in speech. Then she had diplopia as well as ptosis, and all these symptoms used to be better in the morning, because many audience are not from the neurology. So I have just brought the video of the patient so that they can get aware of such condition. This is a classical case of myasthenia in which the patient is having predominant proximal muscle weakness. He is unable to stand. She needs support to get up from the chair. She is having ptosis, and she is having nasal intonation in the speech. She is having difficulty in swallowing as well as difficulty in speaking. So when she came to us, she was also having complaint that she was not taking proper sleep during the night time. And when we got the ABG during the night time, he was getting CO2 retention as well as the poor chest effort. So there are many more conditions apart from myasthenia gravis which the patient was having, which are involving the neuromuscular system, like starting from the anterior horn cell to the roots like GBS or neuromuscular junction like myasthenia, or the myopathies like polymyositis or genetic muscular dystrophies that can affect the quality of sleep because of the poor sleep effort or the diaphragmatic weakness or the kind of peripheral obstructive sleep apnea. And in such patients, the respiratory distress is because of the pulmonary restriction or increase in the airway resistance or hypoventilation, decline in chemosensitivity to blood gas, or some CNS related events. In such patients, the timely institution of positive airway pressure during the sleep can save their life, or at least prolong their life in conditions of neurodegenerative conditions like degenerative myopathies. Now, one more interesting case of a 25-year-old male who got a symptom. We all know the famous story of Ondine curse, when a normal man got fall in love with a mermaid, and they were happily living. Then once inside the water, then once the man got all the memories of the land, so he wanted to come back to the his home on the lands. So, but the mermaid asked her to promise her that she will not fall in love with another woman. But when the man came out of the water, he fell in love with another woman, and after that he got married and he forgot the mermaid. So mermaid cursed her that he will be able to breathe only when he will be awake, and as soon as he will fall asleep, he will stop breathing. So finally the man died. The similar scenario appeared in this 25-year-old male who was apparently well before this onset of the symptom, but he had one morning he had acute onset weakness of all four limbs, as well as along with this weakness, the catastrophe was not enough. He was also having sleeping disturbances because he used to stop breathing as soon as he falls asleep. So he was put on mechanical ventilator, and later he was put on tracheostomy. And upon getting the MRI, he was getting long segment demyelination involving the cervical cord as well as the brainstem. And because of the demyelinating pathology of the brainstem, he was there was involvement of the respiratory centers in the medulla, and that's why he was unable to maintain his breath while falling asleep. So he was given long-term respiratory support, and somehow his symptoms persisted for 3 to 6 months, and then only he was able to get extubated. So these were few of the interesting cases which we neurologists commonly deal. These were the some common examples. And apart from that, the sleep and neurology, the relations mostly intervened. How can we forget the residents who were working days and nights during the phase of pandemic, and those because of the tightly packed these PPEs leading to sleepless nights and all this hard work. So these kind of insomnia commonly occur during the residency phase. So neurology, not only neurology, but all the medicos are commonly having these kind of sleep problems. So this presentation is dedicated to all those medicos who are consuming or who was investing their sleeps for the care of the patients. Thank you.
Thanks a lot, Dr. Govind Madhaw. Thanks for joining all together from Ranchi. It was really a very good presentation, a nice presentation. Presentation get live through the the video recorded by your you or your residents. So it was really a very nice presentation. The case study you discussed is is a very live related to neuropathic pain and sleep. And the recorded the video of the old patient complaint and the woman video of this RLS and periodic leg syndrome. So it's a eye-opening for our all the budding practitioners who are going to treat the patients related to neurological issues or sleep related issues. It was really a very nice presentation from your side. There is a question, I think, sir, how as you being, just hold on. Sir, how as you being a neurologist maintain a good sound sleep? There is a direct question to you. Yes.
This is really difficult. We often teach the patient to maintain a sound sleep, but we being a doctor somehow don't imply these rules to us. So this is a common problem to all the doctors.
Yes. So the doctor should given the proper rest, and their shift hours should be also, so that they can treat the patients and they themselves should be, healthy, then they would be, treat the patient and let them healthy and all. So any other questions from audience? Any participant? You just